Good evening, everyone. I'm going to start the presentation. I'm Dr. Ashrita, developmental and behavioral pediatrician working at Andhra Hospitals. Today, I'm going to discuss about approach to global developmental delay child. I'm going to do this as a series of cases actually. Today, I'm going to present you the theory part. In the next coming presentations, I'm going to present you the case scenarios and also the home stimulation videos which we can all do at or which we can all suggest our patients to do at home, parents to do at home. So coming to the theory part of global developmental delay child, I know everybody is almost seeing two or more global developmental delay children in their OPD per week. So we have taken this topic today to discuss about it. So what is the definition of a global developmental delay? It is defined as a significant delay, at least 2 standard below the mean, in at least 2 developmental domains in children less than 5 years. They should not have any primary motor or visual or any hearing impairment. And global developmental delay is also a subcategory in under intellectual delay in DSM-5. Recently, they have included GDD as a subcategory. And what is the prevalence? The prevalence ranges from 1 to 3% of your pediatric population. Global developmental delay and ID, intellectual disorder, these two have a common features. That is, there is a disorder of, they both are the disorder of cognition, and all the children who are meeting the criteria for GDD is not necessary that all these children will later develop ID. Why the reasons might be there might be a maturational effects, there might be change in developmental trajectory, because we are using the GDD diagnosis as very imprecisely we are using the diagnosis GDD, and they have also reclassified the disability categories. So these are few of the reasons why all the GDD children, particularly below 5 years, they may not develop into ID. So what we should do? We should do some developmental surveillance and screening. What do you mean by developmental surveillance? Developmental surveillance means documenting the developmental history, writing down or eliciting the parental concerns, and also performing some developmental examinations, identifying the red flags. Have to do the developmental examination by doing some screening tests. What are the screening tests? The screening tests are something like brief standardized tools for identifying the risk of developmental disorders. So for all the children, routine developmental surveillance we should be doing till 2 years of age when they are visiting your OPDs for every immunization by using some age appropriate milestones. In addition to that, we have to use some specialized screening tools at 9 to 12 months, 18 to 24 months, and also during school entries. If there are high-risk infants who are following up with you, in addition to the normal developmental surveillance, screening should be done at 4 to 6 months, 9 to 12 months, 18 to 24 months, until 5 years of age for high-risk infants, and also during the school entries. If there is a child who is diagnosed as global developmental delay visiting your clinic, you should also screen them for autism spectrum disorders at the age of 18 to 24 months. This should be in your routine developmental surveillance. If the child is not meeting the criteria, you should again screen the child for autism at 3 years of age. So what are the common developmental screening tools we use in India? One is age and stages questionnaire. We can apply it from 1 month to 66 months. We can use Denver developmental screening test. It is applied between 0 to 72 months. We can use developmental profile. There are two kinds of developmental profile. One is for 0 to 12 years. The other one is for 0 to 21 years. And there is one RBSK screening tool. They mainly rule out the visual and hearing impairments. And there is one more very easy tool called TDSC, SC, which is Trivandrum Developmental Screening Chart that can be applied for 0 to 6 years. And there is one more tool called Baroda Developmental Screening Tool, which is applied for 0 to 30 months. These are the most commonly used developmental screening tools. So what are the possible causes of global developmental delay? We already know all the extensive list, but I tried to put it in a simple box so that you can easily remember for your, practical exam. So mainly prenatal, perinatal, and postnatal. In prenatal also we have something called acquired and non-acquired. So genetic, mainly trisomy 21 fragile X. Metabolic causes like metabolic causes or IEMs, CNS malformations, and anything due to teratogens, toxins, or infections. These all yield up to 21 to 40% of your 47% of your diagnosis. These may be the percentage leading to the GDD in a child. Perinatal causes might be asphyxia, prematurity, neonatal complications like bilirubin encephalopathy, meningitis, encephalitis sequelae. All these are the perinatal causes that might be leading up to 55% of your diagnosis. And postnatally, most common causes might be neglect or any psychosocial environment, any infections, post-traumatic causes or toxins. It is causing up to 11% of your diagnosis. So how do you clinically evaluate if you have a child with GDD? So main thing in all developmental problems, the main thing we have to, the main hero is history part. So antenatal, perinatal, and postnatal risk factors we have to rule out. And most importantly, family history. Family history, preferably we have to take 3-generation pedigree chart, looking for any consanguinity, recurrent marriages, any birth defects, any explained infant deaths, or any global developmental delay or intellectual disability, neurological conditions, or any genetic conditions in the family history we have to note down. And we have to also note down all the milestones according to the domain wise. And also in your physical examination, you should never miss anthropometry, including head circumference, head to toe examination. You have to note down all the major and minor dysmorphic features, any neurocutaneous markers, and complete detailed neurological examination. And also one of the main part which we miss is we have to also take the history relevant to the medical comorbidities and also any behavioral comorbidities that the child might land up in. So you have to take all those history properly. So basically, what are all the investigations you generally suggest for GDD? Can somebody unmute and tell me? If a child walks into your clinic with a motor and delay in fine motor area, what are all the investigations you are suggesting for the child? Can someone answer? Or can you put your answers in chat box?
Metabolic.
So metabolic, when you are going to order metabolic investigations, can you be very particular in metabolic means what kind of you are ordering, suggesting? So is there any particular way you are going? I mean, like any first line of investigations or any second line, if first line comes negative then second line or something like that, or you are directly telling a child to get a karyotyping done or toxicology screening?
We usually advise MRI brain, ma'am.
Okay. When do you ask for MRI brain?
If there is any significant perinatal history
Okay.
and any neurological abnormality, like abnormality on neurological examination.
The main purpose of me taking this topic to explain in detail the theory part is the investigation part. Uh, so there should be always a way to evaluate the child. You shouldn't order all the investigations at once. What should be your main aim? Your main aim should establish the etiology. So you should understand the risk also, and you should also identify the comorbid conditions. All whatever investigations you are suggesting, your investigation should at least fulfill all these things. Like it should cover up your etiology. You should understand through your investigation if the recurrent risk is there or not. I mean, like, can you rule out the recurrent risk? And if there is any comorbid condition, you are identifying it or not. I'm very happy somebody told hearing assessment. That's the right answer. So while investigating, we have to do some appropriate investigations, and you should always think of your resources also, and also you should keep in your mind all the clinical clues what you got from the history. You should never miss that point, because there is no point if you're not keeping all the clinical clues in your brain. If you're directly ordering a MRI or a karyotyping does not suggest your problem. And visioning and hearing should be a must and should when you suspect a GDD. So I have divided in them into 4 parts. So for the treatable causes, first we are taking the history. There are any treatable causes if the history is suggestive of some hypothyroidism or something like that. So TFT, iron and vitamin B12 and CPK levels. These are the treatable causes we can. So treatable causes, and if there is any abnormal head size or any other neurological findings or any other seizure, then only we'll go for neuroimaging or any EEGs. And if there is any family history suggestive of consanguinity or positive family history or any developmental regressions, then we have to go for a IEM or TMS or GCMS test. If there is no clear etiology or any other genetic or any other syndromic features, then we'll go for genetic testing. So when do you do neuroimaging in GDD? Normally, if you are ordering on MRI for any GDD case, 30 to 70% you will get a positive finding in GDD. Something or the other you will get a finding from your MRI report. But will it help in your diagnosis? Only 10 to 40% it will help in your diagnosis. It won't solve your problem. So when you are going to order the neuroimaging, when neurological abnormalities, if you are finding like any head size or any abnormal head size or any seizures or any other findings like any tone abnormalities or any movement disorders or any other thing, then you can go for a neuroimaging imaging in GDD. So it should be done, it should not done in screening basis, it should be done in an indicated basis on history and clinical judgment. So EEG metabolic testing. EEG, as I already told you, when there is a history suggestive of epilepsy or any epileptic syndrome, then you'll order. And when do you order metabolic testing? We'll order metabolic testing as second line of investigation only when neonatal screening is not done, and also if there is any history of consanguinity or any familial history of similar illness or any unexplained miscarriages or any history suggestive of metabolic testing. So one more biggest dilemma everybody will get is when to do genetic testing and if at all what to do. So if there is any specific chromosomal or micro deletion type in your brain, like if you are seeing any features suggestive of Down syndrome or any particular syndrome, then you can go for conventional karyotyping or fluorescent in situ hybridization or MLPAs. If it is fitting into any specific gene disorder like Fragile X, any ID, like if you feel that there is a lot of cognitive and motor delay in a male child with a similar history in a family, so then you can go for any PCR or Sanger sequencing or any metabolic testings. If there is unexplained GDD with or without autism or any if there is any dysmorphism or any major congenital anomalies, you can go for chromosomal microarray. If normal chromosomal microarray comes and still your global developmental delay is unexplained, if any monogenic disorder is suspected, you can go for exome sequencing. So what are all the normal comorbidities you will see, which we all tend to miss in GDD? We always feel that GDD means there will be some motor delay. Motor delay, we'll go for a physiotherapy. We'll always ask the child for motor and we'll go for neurological examination. We'll leave it there. But we should always consider the comorbidities. There will be a sleep disturbances. There will be pseudobulbar dysfunctioning, droolings, constipation, PM, which we many times will all ignore the child. We'll mainly focus on motor delay. So try to keep in your brain when you are talking about the comorbidities, when you are dealing a GDD child, we should always think about neurological, non-neurological comorbidities like all the infections, drooling, PM, constipation, malnutrition, and also the main important part is behavioral or psychiatric part, because most of the GDDs, they might have anxiety, aggression, mood disorders, autism, and also few of them might be landed up in ADHD also. So how will you manage? So what are some of the early intervention strategies you are following at your place for any developmental? If there is, you might be doing some risk stratification for your neonates at NICUs. So what kind of early interventions you guys are doing at your workplace or study place? Everybody will talk about some early intervention, right? What's the early intervention that you guys know? Can somebody unmute and say? Or can post it in chat box also.
Some stimulation methods like oral stimulations and
Okay. What else we can do in a neonatal intensive care unit, which is very basic and a very early intervention kind of thing, which helps in neurodevelopmental this of the child, neurodevelopment of the child. Yes, KMC is the right answer.
games.
So always bringing the parents with the child, with the baby or the neonate is the first basic step of your early intervention. And also, as you rightly said, all the early stimulation exercises also. Okay, so it should start, you should always first stratify the risk stratification should be there for your neonatology unit, and accordingly you should take the support. If the child is very high risk, you coming into your high risk zone, so you should involve some extra help like therapists also, some oral some motor exercises, all those things as your basic thing in your early intervention part. Otherwise, the KMC, reducing the sound, light, all those things comes under early intervention of your for infants in NICU. So you should always identify the treatable causes first when your child walks into your clinic with GDD, and always order investigations accordingly. Mainly, you can relate iron, hypothyroidism, all these things. So potentially treatable causes should be identified, and specific treatment should be started. And we should always provide all the routine health care. As I already told, healthcare interventions should be included at all levels of care. Even if you are in the primary level of care, you should always consider the diet part, immunization part, should see whether the child is going into dental caries or sleep disturbances. And also you should get the basic vision and hearing part get checked for the child. So all this routine care should be done. And when the child walks in, when you recognize that the delay in the first visit, when the child is coming to you for the consultation, and when you have identified the diagnosis, or when you have given the tentative diagnosis, the early intervention part should be started immediately after your formal diagnosis. So you should always screen comorbidities also. So behavioral problems, if there are any epilepsy, anything, medication required, or cerebral palsy. So you should always include ortho part also, and also visual and hearing part. And for any seizures, when in EAG is indicated, you should get the EEG get done. Okay, so any other if the child is coming to you around 6 to 7 years, you should never miss the preschool education part. You should always include the special education part also in your management thing. So how will you explain prognosis and follow-up? So he will always come to you. So primary pediatrician is very important. You should support the family, reassure. You should ensure that you should see whether the parents are ready to take the diagnosis part properly, whether they are taking the therapies, why the therapies are important. All these things should be explained to the parents, and regular follow-up should be maintained. So whenever, if you have a resources for developmental pediatrician or any pediatric neurologist, you should always consider that, and you can include them in your team and help the child. So this is how. So you should take, if you have identified any developmental delay in more than 2 developmental domains, so you are going to take a detailed history, and as a first basic step, we are going to assess the hearing and vision part, and we are going to screen for comorbidities. How? By asking, by taking the history. Okay, and we are planning investigations accordingly based on our clinical assessment, and we will start our early intervention. So what are the treatable causes? So these are the tests we'll order, like thyroid function, iron, vitamin B12, CPK levels. And if there is any abnormal head size or anything, then only we'll go for a neuro imaging part and EEG if there is epilepsy. So if there is any positive history, then we will check for newborn screening. If it is not done, then we'll investigate for IM. If there is no clear etiology or there is any suspicion of any genetic syndrome, then we'll go for genetic testing. If at all your diagnosis is established, still if after forming a tentative diagnosis of developmental delay, still your therapist will be going on, the diagnosis will come much later part. So if it is established, okay, the treatment you are, if at all any other additional required treatment is necessary, then you will add it up. Otherwise you will start your early intervention and you'll go accordingly, because the only uh, management part is by helping the child not to landing up more into motor delays or any other comorbidities. So you have to start your intervention immediately. So what are the take home messages? Early identification, okay. So management part and multidisciplinary intervention should always be included. So always a role of pediatrician is important, because they'll come first to you, and you should be like an anchor between multidisciplinary team and the parents. And you should always never miss out vision and hearing part. And neuroimaging will be done only when indicated. So that's how I simplified this talk. If you have any doubts, you can post a question on chat box, or you can ask me directly. In next part, I'll show you some case scenarios. In next session, I'll show you some case scenarios, and also have to guide the parents for home stimulation. What are all the exercises we can tell at home for particular milestones.
Thank you, Ashita. It is a clear and lucid presentation. And because no one is answering the questions, I think I have to answer some questions. And so I missed the initial part. So what is the difference between global developmental delay and ID?
Sir, ID is generally we suspect in more than 5 years child, if if the child is less than 5 years and if there is any delay in 2 domains and there is a cognition involved also, then we'll call GDD. So ID more than 5 years, because the child is not fit for sitting into any IQ test or anything less than 5 years. So we call it as GDD, and more than 5 years we call it as ID.
Okay, if say for example a 7-year-old child came to our OPN, child's milestones are say it's only 1.5 to 2 years.
Still we can call them as GDD, sir, because they are not compatible for doing any IQ test. So all those children who are not fitting into the category, or they are not ready to sit for the tests and all, those also children we can call them as global development. We can also consider age part.
Okay.
అలా పెట్టండి, మందులు పెట్టండి అమ్మా.
అష్ట ఒకసారి మ్యూట్ చేయ అందరిని ఒకసారి. Others can mute yourself.
Yeah, sir. So basically GDD means less than 5 years, or else if the child is not eligible to do any tests, that kind of child also, if there is any deviation, in two domains, and cognition involved, we'll call as DDD. But ID, if they're sitting particularly at cognition involved, then we'll call it as ID, provided age is more than 5 years.
Okay. And one more thing, question is like, if you see an intellectual disability child, is it always necessary the child should be a global developmental delay, or like it can be only intellectual disability without a global developmental delay in the earlier age?
In earlier age, they'll not be necessarily GDD, sir. Sometimes there will be a slight delay, not a very, very gross delay. But sometimes only cognition involve, motor involve, abbaledu, then we can't say. So all the IDs should be GDD ante ledu. All the GDD should be ID anna kuda ledu. It's not necessary.
Okay. And I have seen one thing in the treatment, treatable conditions, you are asking for a CPK. So how the CPK is going to help in global development delay in treatable conditions?
Sir, mom, if a male child with hypotonia, okay, they came to your this thing. So identifying at a early cause ante CPK treatable causes CPK ante not exactly treatable but partially treated GDD.
Partially treated. So I think it's mainly for Duchenne muscular dystrophy, I feel.
Yes, DMD.
Yeah, that is true.
But that male child will also have a normal milestone in particular age. So suddenly they will be starting వాళ్ళకి they'll have this motor this thing gover sign positive atla vastadi. But for that child లేకపోతే if they have any poor schoolistic performance and వచ్చారనుకోండి, for suppose they get it to your clinic at 7 years, so unexplained this thing, you can order for a CPK, అది కూడా to rule out DMD partially అంతే.
Okay. I think they should have changed it from treatable conditions to some.
Okay.
That is what I feel. Okay. I think that's all from my side. If any others want to ask, they can ask. And some are asking some developmental quotient calculation and developmental assessment. So I think you can do one video and they can post in our academic group. So how to assess developmental. That will be easier than a class.
Sure.
Okay, if no more questions, I think we can conclude the meeting.
Okay. Thank you, everyone. I'm concluding the meeting.